friends, welcome back to my channel. Today I am going to discuss a vast topic, that is implantology. In this lecture, I would like to share the details regarding the basics in implantology. So let's begin. Here I am trying to share the details regarding the textbooks by Colmish, Contemporary Implant Dentistry and Dental Implant Prosthetics. So these are the basic textbooks I followed for my videos. So I would like to share these topics in my lecture. Coming to the introduction. What is our goal? Our goal of modern dentistry is to restore the patient to normal contour, function, comfort, aesthetics, speech and health, whether restoring a single tooth with caries or replacing several teeth. What makes implant dentistry unique? It is the ability to achieve this goal regardless of the atrophy, disease or injury of the sternognathing system. Okay. Let's begin with the definition of a dental implant. A dental implant, according to Glossary of Prosthodontic Terms, it is a prosthetic device which is made up of alloplastic materials. It is implanted into the oral tissues beneath the mucosal and periosteal layer and within the bone to provide retention and support for a fixed or removable dental prosthesis. So it is a prosthetic device. Okay. What it is made up of? It is made up of alloplastic material and it is implanted into the oral tissues beneath which layer? Mucosal or periosteal layer or within the bone to provide retention and support for a fixed or removable dental prosthesis. Otherwise, it is defined as a substance that is placed into and upon the jawbone to support a fixed or removable dental prosthesis. Okay. Let's discuss what are the differences between a natural teeth and a dental implant. A natural teeth, this is the natural teeth and this is a dental implant. Okay, here this is the natural tooth crown with enamel outside and dentin inside. Here the periodontal ligament is there. It connects the tooth root to the bone. Okay, this is the periodontal ligament. It connects the tooth root to bone. Okay, and here this is the dental implant. This is a natural looking porcelain crown. It is made to match your natural teeth. This is the implant abutment. It is the connector between the crown and implant. Here, bone actually grows onto the implant surface to hold it securely into place. Okay. And this is the natural tooth. This is the natural tooth crown. An implant and crown mimics the form and function of your natural tooth. And tooth root, it holds the tooth in jawbone. Implant surgery replaces your natural tooth root with a titanium implant. Okay. Here this is the custom made crown. It is fitted after the implant has been surgically placed. This is the abutment. It connects an implant to a dental crown. It allows the crown to be securely attached and this is a dental implant. Foundation for your implant crown or bridge. Generally made from titanium. Bone grows onto the implant in a process called osseointegration. Okay. And when a tooth is lost due to some injury or a disease, and the patient or person can experience some complications such as rapid bone loss or defective speech or changes to chewing patterns which result in discomfort. And replacing that lost tooth with a dental implant can significantly improve the patient's quality of life and health. This is the anatomy of an implant. Here it is crown, then this is the abutment and this is the implant. And the uses are single tooth replacement, implant supported bridge and full arch replacement. Coming to the rationale of implant treatment. The life expectancy has increased significantly past the age of retirement. So life expectancy has increased more rapidly since 1960 than at any other time in history. Because of the tooth loss, it is directly related to the age. A growing number of adults are missing teeth. So the response should be very positive as the patient's life expectancy will extend for 2 more decades and their current oral situation will normally become worse if not corrected. Here, when a person reaches 65, he or she often feels an investment in health is less appropriate. A 65-year-old healthy woman will live 23 more years, 50% of the time, and 29 more years, 25% of the time. And her present oral condition will become worse during this extended time frame if the treatment is not rendered. This is the frequent occurrence in a general practice. Here, this is the posterior missing tooth. Okay, almost 80% of the time, the adjacent teeth are unrestored or have minimum restoration. So, most common teeth missing is mandibular first molar. Okay, this is the most common teeth missing. Here, this is a 3-unit fixed partial denture. It is the most common method to replace missing teeth in the posterior regions of the jaws. To replace the missing teeth, the teeth adjacent to the space are crowned and missing tooth is attached to the crowns. This is the most common used method for replacing a single tooth. Here, this is a 3-unit fixed partial denture. It most often fails because of the caries on a crown margin next to the pontic. Okay. Here the abutment teeth of a fixed partial denture often decay at the margin next to the pontic because it acts as a plaque reservoir and rarely has adequate daily hygiene. For single tooth replacement, the most common method used is fixed partial dentures. Estimated mean lifespan of a FPD reported at 10 years. That's 50% of survival. Caries is the most common cause of FPD failure. 15% of FPD abutments require endodontic treatment. Failure of abutment teeth of FPD 8 to 12% at 10 years and 30% at 15 years. And 80% of teeth adjacent to the missing teeth have no or minimal restoration. So, single tooth implant in the posterior region of the mouth is most often the treatment of choice. Okay. Here, a single tooth implant is used to replace a missing tooth. It has highest success rate and the adjacent teeth are less likely to decay and require endodontics or result in additional tooth loss. Even when the teeth adjacent to the missing tooth require crowns, so these are adjacent teeth require crowns, but implant is a treatment of choice because single crowns on the teeth adjacent to implants have fewer complications and increased longevity compared with abutments for a 3-unit fixed partial denture. Hence, for a single tooth replacement, implants are the best choice. What are the advantages of single tooth implants? High success rates, above 97% for 10 years. Decreased risk of caries of adjacent teeth, endodontic problems on adjacent teeth. Improved ability to clean the proximal surface of adjacent teeth. Improved aesthetics of adjacent teeth. Improved maintenance of bone in the edentulous site. Decreased cold or contact sensitivity of adjacent teeth. Psychological advantage. Decreased abutment tooth loss. These are the various advantages regarding the single tooth implants. And there are more than 44 million people in the United States missing at least one quadrant of posterior teeth, most often in the mandible. And problems with the removable partial dentures, that is low survival rate, it is 60% at 4 years. 35% survival rate at 10 years, repair of abutment teeth rate 60% at 5 years and 80 at 10 years, increased mobility, plaque, bleeding upon crabbing and caries of abutment teeth, 44% abutment tooth loss within 10 years, accelerated bone loss in edentulous region if wearing RPD. Okay, so these are the problems with the RPD. And here is a panoramic radiograph which demonstrating that more bone is maintained below the anterior periodontal diseased teeth compared with the basal bone loss and severe atrophy of the posterior edentulous segment. Okay, so here this is the more bone is maintained below the teeth compared to the basal bone loss for the atrophied ridge. Okay, atrophied posterior edentulous segment. So wearing of a mandibular class 1 RPD has escalated the posterior bone loss. Even periodontal involved teeth may maintain more bone than RPD because the denture may cause basal bone loss. And what are the consequences of complete edentulism? Actually, there are many negative consequences for completely edentulous patients. They include continued bone loss of the jaws, soft tissue changes of the jaws, negative facial aesthetic changes, decreased masticatory performance, diet-related health issues, and psychological aspects of a total tooth loss. So these are the various consequences of complete edentulism. And these are the various aesthetic consequences. So the facial changes naturally occur in relation to aging process can be accelerated by the loss of teeth. Every dentist is aware that the dental skeletal position will affect the facial aesthetics. And the face is more supported by the bone than the teeth. Here the aesthetic aspects of the inferior third of the face are not only related to the position of teeth but also the amount of bone in the jaws and include the muscles that attach to the bone. So these are the aesthetic consequences. Here this is the picture showing a patient often wears a denture for more than 15 years. Okay, this is the after 15 years the patient. So here the loss of vertical dimension result in many changes. So that is collapse of edentulous bite. Closed bite is there. Mandible will forward, rotates forward. Receding maxilla is there. Reverse smile line. Increased number and depth of the lines in the face. More acute angle between the nose and face. Loss of vermilion border in the lips. Which chin from loss of muscle attachment. So these are the changes observed after a patient wearing a denture for 15 years. Okay. And here this is the loss of bone height which can lead to a closed bite with rotation of a chin anterior to the tip of the nose. And here severe bone loss is there in the maxilla and mandible. Although she is wearing 15-year-old dentures, the facial changes are significant. Here this is the which chin. Okay, that is ptosis of the chin. So loss of muscle attachments lead to ptosis of the chin. That is which chin. Loss of vermilion border, that is lipstick is applied to the skin. Reverse lip line. Decrease in the horizontal angles. Increase vertical lines in the face and lips. Increased lip angle under the nose. Lack of body in the masseter and bucciniter muscles. So this is the panoramic radiograph of a 68-year-old female. Here it shows the maxillary arch which has severe atrophy and almost complete basal bone loss is there, including most of the nasal spine. Here the implants were inserted in the anterior mandible 15 years before this film. The anterior bone has been maintained and the posterior mandible shows continue to resorb and the mandibular canal is dehiscent on one side. This is the profile view of that patient. Not the maxillary bone loss effect, that is lack of vermilion border of the lip, deep labial folds and columella philtrum angle. Right? The lower lip has a normal vermilion border and the muscles to the lower jaw are still attached, providing a normal contour. So this is the bone loss. Here alveolar bone which forms as a result to the formation of Herdwick's root sheath which forms the tooth root. When no primary or secondary tooth root is present, alveolar process does not form. This panoramic radiograph is from a 35-year-old patient with ectodermal dysplasia with complete anodontia, that is tooth loss of both primary and secondary teeth. Basal bone developed but not the alveolar process. 3 anterior implants in the mandible help to retain the lower denture. After the initial extraction of the teeth, the average first year bone loss is more than 4 mm in height and 30% in crustal bone width. And here the rate of bone loss is lower after the first year. The bone loss is continuous throughout the life. Here this is the dentate mandible on the left and long-term edentulous mandible on the right. Okay. Here the amount of bone loss in height. Loss of bone height in the mandible may be measured by the centimeter and often is ignored. Such bone loss is often more significant than the bone loss from periodontal disease. And the patient should understand that the denture often replaces more bone than teeth to restore the proper dimensions of the face. And the rate and amount of bone loss is influenced by gender, hormones, metabolism, parafunction, ill-fitting dentures, facial type, that is brachiocephalic versus dolichocephalic, time period dentures are worn. This is the Atwood's classification. He described 5 stages of resorption in the anterior mandible. Stage 1, it represents the tooth and surrounding alveolar process and the basal bone. Stages 2 and 3 illustrate the initial residual ridge after tooth loss, and 4 to 6 primarily describe a continuous loss in height of anterior residual bone. Residual ridge resorption is discussed in detail in my another video. You can watch that video. Here the panoramic radiograph which demonstrates a denture. It may restore the vertical dimension of the face, but bone loss can continue until the basal bone is paper thin in the maxilla and mandible becomes size of a toothpick. Okay. So this is the resorption of an edentulous mandible. It results in dehiscence of the mandibular canal and associated paresthesia. Okay. And the patient may fear that a tumor is growing against the nerves. The body of the mandible may continue to resorb until minor trauma causes fracture, as in the panoramic radiograph. That is during mastication, bump of a baby's head held closely to the face, or an accidental bump from the elbow. Okay. These are the various conditions which have an effect on vascular supply and soft tissue quality under the removal processes. That is patient's age, hypertension, diabetes, anemia and nutritional disorders. This is the patient with moderate to severe atrophy. It has the intraoral muscles above the residual ridge, including floor of the mouth and the mentalis and buccinator muscles. Tongue is also larger in size and plays a more active role in mastication. And these are the soft tissue consequences of edentulism. Attached or keratinized gingiva is lost as bone is lost. Unattached mucosa for denture support, which causes increased soft spots. Thickness of the tissue decreases with age, and systemic disease that cause more sore spots for dentures. Tongue increases in size, which decreases the denture stability. Tongue has more active role in mastication, which decreases the denture stability and decreases neuromuscular control of jaw in elderly adults. And coming to the consequences of bone loss in fully edentulous patients, there is decreased width of supporting bone, decreased height of supporting bone, and there are mylohyoid and internal oblique ridges prominent, and the increased sore spots, progressive decrease in keratinized mucosa surface, prominent superior genital tubercles with sore spots, increased denture movement, muscle attachment near the crest of the ridge, elevation of processes with contraction of mylohyoid and buccinator muscle serving as posterior support, then forward movement of processes from anatomical inclination, that is angulation of mandible with moderate to advanced bone loss, thinning of mucosa with sensitivity to abrasion, loss of basal bone, paresthesia from dehiscent mandibular neurovascular canal, more active role of tongue in mastication, effect of bone loss on aesthetic appearance of lower third of the face, increased risk of mandibular body fracture from advanced bone loss, loss of anterior ridge and nasal spine causing increased denture movement and sore spots during function. Coming to the psychological effects of tooth loss. It ranges from minimal to neuroticism. Neuroticism is something that affected with an emotional disorder or a characteristic or affected by neurosis. Then romantic situations affected. Then oral invalids who were unable to wear the dentures. And 88% claim some difficulty with speech and some claim significant problems. And most often they spent on denture adhesive to decreased embarrassment and dissatisfaction with the appearance, low self-esteem, then avoidance of social contact. And coming to the advantages of implant supported prosthesis. Here the bone loss in the edentulous patients may be dramatically stopped by using implants to support the prosthesis. So what are the advantages? It maintains the bone, it restores and maintains the occlusive vertical dimension, then facial aesthetics can be maintained or muscle tone, then aesthetics, improved aesthetics, then in phronetics, occlusion, improve oral proprioception, increase prosthesis success, improve masticatory performance or maintain muscles of mastication and facial expression, reduce size of prosthesis, provide fixed versus removable prosthesis, improve stability and retention of removable prosthesis, increase survival times of prosthesis, no need to alter the adjacent teeth, more permanent replacement, improve psychological health. So these are the various advantages of a implant supported prosthesis. So once an implant prosthesis is placed to support and retain the mandibular restoration, the bone in the maxillary region continues to be lost and eventually the patient complains of loss of retention and inability of the maxillary denture to function. And the loss of facial aesthetics is most often noted in the maxillary arch with the loss of vermilion border of the lip, increased length of maxilla, lip, and lack of facial bone support. So implants should be used to treat the continued bone loss and prevent the later complications found in the maxillary arch. Okay. Here, this is a pan of an edentulous maxillary arch with moderate sinuses and a resorbed anterior maxilla. An iliac crest bone graft was inserted into the maxilla and the bilateral sinus graft were also made to the posterior regions. And maxillary implants were inserted after the graft and the maxillary fixed prosthesis was fabricated. The lateral profile of the patient that's shown in these figures, not the support of the maxillary lip. Here it is the high smile line of the patient with the final restoration in place. Okay. These are the implant prostheses which maintain the bone and reduce the bulk of the soft tissue bone process. These are the soft tissue bone processes. So implant processes can reduce the bulk of that soft tissue bone process. Okay. Stability and retention of an implant supported prosthesis are great improvements over soft tissue bone dentures. So mechanical retention is far superior to the soft tissue retention provided by dentures or adhesives and cause fewer associated problems. Coming to the history and evolution of dental implants. This is the ancient era up to AD 1000. Implantation of animal teeth and teeth carved out of ivory was performed on women in ancient Egyptian dynasties. Around 600 AD, the Mayans used implants consisting of seashell segments that were placed on anterior tooth sockets. Hammered gold inlays or stone or mineral inlays were placed for aesthetic purposes or traditional ornamentation. And in AD 600, here this is the mandible which is found in the Honduras in Central America. Here Incas implanted 3 carved incisors made from carved seashells. This is the Ambroise Paré. He is a French physician and a surgeon to 4 kings of France. He replaced the missing teeth with implants made up of bone and ivory. And he successfully replaced the missing tooth of a princess. Albucasis de Condieu, an Arab surgeon, described the transplantation procedures. He attempted to use ox bone to replace missing teeth. And in 1809, Maglio, he is a dentist at the University of Nantes, France. He is the author of a book called Art of the Dentist. Gave the first reference to the modern style implants by introducing the usage of gold in the shape of tooth root. And one of the most significant advances in the history of dental implants came with the work of Swedish physician Per-Ingvar Breinemark. And he was known as the father of modern dental implant technology. He studied the osseointegration, structural and functional connection between living bone and an implant. So this is the osseointegration coined by Breinemark. He described a direct bone implant interface under the power of a light microscope. In 1728, Pierre Fauchard, he is the French dentist, first proposed the use of porcelain in dentistry. This is the pre-modern era. In 1913, Greenfield uses a 2-piece hollow basket fabrication, that is lattice cage, from 24 gauge iridium soldered with 24 karat gold. Greenfield developed a 2-stage implant insertion. This was also the first anti-rotational abutment design. This is the modern era, 1935 to 1970. In 1939, Strock described a method of placing a screw type of implant. It is made of vitalium, that is cobalt chromium molybdenum alloy, to provide anchorage for placement of missing tooth. In 1940, Formigny designed a single helix wire spiral implant made of stainless steel or tantalum. This is the Formigny's first implant design. Here the implant was a wire twisted back upon itself and bone was to surround the resulting spires, giving good retention. Here this is the bone regrowth in a single tooth implant by Formigny. The implantation is partially successful. This is the open socket. Here this is the implant soon after insertion. Here 8 months later. This is over 1 year later. Deeper spirals are surrounded by bone. However, soft tissue encapsulates the superficial spires. In 1943, Gustav Dahl first suggested the construction of a subperiosteal type of implant. What is the subperiosteal type of implant? It is placed onto the bone rather than into the bone, similar to a saddle. And this implant is used most often to cover a large surface area such as a completely dangerous mandible where there has been severe amount of bone resorption and not enough bone to support endosteal implants. So this is the subperiosteal dental implant. Okay. In 1967, this is Linko. Linko introduced the blade vent implant. These are the blade vent implant. This is the Linko self-taping vent implant, shown in numerous variations for almost any bone situation. These are used for shallow alveolar bone. Okay. And here the excellent bone regrowth is seen around the deeper portions of the 6-year post-operative early model vent implant. It is a non-self-taping implant made of tantalum. In 1970, Gottberg group in Sweden, led by Breinemark and Albrechtsen, presented the Nobel Pharma implant, cylindrical root form implants made of titanium. Term and concept of osseointegration coined as well as described by Breinemark. Okay, research on it was into progress since 1950s. Kawahara in 1974 developed a cylindrical ceramic implant. Nisnik in 1982 developed a core vent cylindrical implants. It's made of titanium. In 1978, Kirsch developed IMZ cylindrical implants. Here the surface was coated with titanium plasma spray which increased the surface area. Intramobile element was included in the abutment assembly to replicate the movement of the natural teeth. This is the picture showing the Breinemark and his first implant patient, Mr. Gosta Larsen. Coming to the recommendations for patients. Before choosing dental implants, talk to your dental provider about the benefits and risk and the various things to consider. Your overall health is very important factor in determining whether you are a good candidate or not. And ask your dental provider about the brand and the model of the dental implant system being used and keep this information for your records. Then smoking may affect the healing process and decrease the long-term success of the implant. The healing process of the implant body may take several months or longer, during which time you typically have a temporary abutment in place of the tooth. After the dental implant procedure, carefully follow the oral hygiene instructions given to you by your dental provider. Regular cleaning is very important for the success of the implant. Then schedule regular visits with your dental provider. If your implant feels some looseness or painful, then tell your dental provider right away. And the benefits and risk. The dental implants can improve the quality of life and health of a patient who needs them. However, some complications occur that result in implant failure. It can result in the need for another surgical procedure to fix or replace the implant system. And the benefits are, it restores the ability to chew, restore cosmetic appearance, helps to keep the jawbone from shrinking due to bone loss, preserves the health of surrounding bone and gums, helps keep adjacent teeth stable and improves quality of life. Finally, coming to the conclusion. The goal of modern dentistry is to return patients to oral health in a predictable fashion. Partial and complete dentilless patient may be unable to recover normal function, aesthetics, comfort or speech with a traditional removable processes. And the use of implant dentistry will continue until every restorative practice uses the modality for abutment support for fixed and removable prosthesis on a regular basis as the primary option for all tooth replacement. So implant dentistry is ultimately the primary option for all the tooth replacement. That's all for today's lecture. The part 2 will be discussed in the next lecture. Thanks for watching. Please do like, share and subscribe my channel for more videos.